for having me. From Beaumont, 1,000 miles away, not 100 miles away. So preface with that. So I have a case here. So a 68-year-old guy, he came in, he has no medical history of hypertension, hyperlipidemia, his obesity, his BMI is around 40. He's coming in with 90 minutes of chest pain, diaphoresis, and nausea. You can see on his EKG, he's got ST elevations in AVR, V1, some diffuse ST depressions. So his physical exam at this point, actually hypertensive, his blood pressure's in the 160s, heart rate's about 110. He's diaphoretic, he's mentating well, his limbs are perfusing, his hands and feet are warm. His lungs are clear, and he has no murmurs. So he has an echo done, just as down in the emergency center. See with contrast, and the 4-chamber without contrast. He does have some apical hypokinesis, CF's about 40%. So here's just some still images of his initial angiogram. So you can see that he's got some disease in the proximal RCA. He's got this complicated lesion in his distal left main, about a 95% distal left main lesion. He also has an ostial circ lesion. So at this point, there's consultation with cardiovascular surgeons. He's taken emergently to the OR. He has a balloon pump placed in the cath lab prior to leaving. And he undergoes a CABG with a Lima to his LAD, a vein graft to his OM, and then a vein graft to PDA. Cross-clamp time is about an hour. So then post-op day 1 is when things start to get interesting. He starts to develop ST elevations inferiorly, still intubated at this point. They were unable to start weaning from his pressors. So Swan-Ganz, which was placed in the OR, you can see the numbers here. CVP was 15, his PA pressure was 40 over 11. Calculates out a PAPI of about 2. His output's 4, with an index of 2, and his CPO is 0.79. You can see on his ECG, which is changed from his prior ECG, he has ST elevations now in the inferior leads and 2-3 AVF. So at this point, they decide to do TE, which is performed in the surgical ICU. So here, you can clearly see, so EF is still preserved, probably about 40 to 50%, but there is in the 4-chamber in the TE, the RV free wall does appear to be hypokinetic. So we thought that might be the issue. So at this point, with the ischemic changes, he was taken emergently to the cath lab. He started on IV Cangrelor, and then here are his initial hemodynamics with the Swan. So his RA pressure at this point is 19. RV pressure is 30 over 19, PA of 30 over 22 with a wedge of 22. His output is actually high at 7. His PAPI is 1.6. So we shoot the native coronaries first. You can see competitive filling in the LAD from the Lima. Same with the OM, so the vein graft to that OM, that circ system. And here is the native right, which is known to be diseased. The vein graft to the OM appears to be dilated and ectatic. Looks like there's maybe a valve there, but overall the graft looks patent with good distal flow. Here is the Lima, and at the anastomosis looks to be openly patent with good distal flow. We shoot the graft to the PDA, and you see this ostial lesion, this filling defect right at the beginning of the takeoff of the graft. There's good flow down the graft, but obvious defect there. So during his diagnostic cath, his blood pressure starts to decline. Blood pressure Begins to drop to the 70s, 70 over 47. His balloon pump at this point is replaced for an Impella CP device via the right femoral artery. So the surgeons came down to the cath lab at this point, and there was a discussion about how to fix the right, which we thought was the culprit lesion and causing his shock. So they initially attempted to fix the native right. They had a lot of difficulty engaging the coronary, and then once we were able to actually pass a wire, the wire went subintimally and dissected, and then the artery shut down at that point. So you can imagine he got a little sicker. His RA pressure went to 20. His wedge was still about 20 or 1. His PA pressure was 30 over 22. His LV pressure was 85 over 11. And his CPO at this point was 0.7. His PAPI was 0.4. So we were suspecting significant RV shock at this point. His PA sat was about 39%. So he then had an RP Impella. This was inserted via the right femoral vein. And he, within 1 or 2 minutes, he had pretty significant improvement in his hemodynamics. So then the attention was turned to the vein graft to the right. Was after a lot of difficulty and different wiring techniques, we're able to wire into the graft and balloon it and stent it. Here's the final result of the vein graft. Here is his transthoracic echo performed the same day. So you still see some RV dilation. LV function looks about the same as prior. So the RV and LV Impella were weaned 4 days later. He did have a prolonged hospital course. It was complicated by acute encephalopathy, atrial flutter, chronic respiratory failure. Did end up requiring a tracheostomy during his hospital stay. He also had a DVT. So he was discharged to inpatient rehab on post-op day 36. He left the hospital 2 weeks later, and he's still doing well. Tracheostomy was reversed. And that's it.
So that's a fascinating case, a difficult, long, tortuous course. In retrospect, do you think he was having a STEMI related to his left main on presentation?
Yeah, that's possible. He did, again, his blood pressure was elevated on initial presentation, but he was kind of complaining of a lot of chest pain, and he did look pretty sick, so I think he was probably in the category B stage, so I think he was kind of impending shock at that point.
Is there any enthusiasm on the panel for a primary PCI approach in this patient, or would everyone agree with the surgical approach?
I would go with the surgical approach given the kind of anatomy. It was distal left main bifurcation lesion involving the ostial circumflex and the LAD, calcified RCA, good targets. I think it was definitely very, very reasonable to stop at that point. The guy was stable, put in a device, and get him evaluated by CT surgery. I think unless there's an extreme situation where you have no option but to go ahead and revascularize, this was not the case. I think this one you could stop, stabilize, and get CT surgical evaluation.
Okay. And just a little caveat, we don't have access to ECMO at our institution, so that's one thought as to why we would use RP Impella versus LV Impella.
That's a great case and a great save. I'm just sort of, this is the comment, I'm astonished that the surgeons actually did a pedicled, skeletonized Lima graft in the setting of a left main, STEMI. Okay. I think our surgeons would reluctantly take these, grudgingly take these cases, but just throw a couple of grafts on there, a couple of vein grafts on there, and try to get them reperfused as quickly as possible. And taking down the Lima, and I defer to the surgeons in the room, as I understand it, is a bit more laborious and takes more time to get that done quickly.
So the other thing I noticed in this case, obviously, one of the biggest challenges we have in somebody who's post-CABG day one, having an ST elevation MI, and you know based on the EKG that it looks like the graft of the RCA is probably gone as was shown in the angiogram thereafter. You know, the question is, how do you revascularize these guys? Do you go with the native? Do you try and fix the osteal lesion, which is a fresh anastomosis here? And so the risk is always you're worrying about perforation, and that becomes a bigger problem on top of the ensuing cardiogenic shock. So it's always a huge challenge. Fresh CABG patients having a STEMI, how do you approach it? I would have done exactly what you guys did. I would have gone with the native at that point and tried. Obviously, it sounds like you guys had a dissection and the flow shut down. And then the next option, with that flow shutting down, you saw your wedge and the RA pressures basically equalized. Your PAPI dropped on table. The RV failure just worsened on table. And I think the next option would have been, before revascularizing the graft to the RCA, would have been to put in some kind of a support device for the RV, which you guys had access to, RV Impella. So I think a bipolar approach at this point was reasonable. And then go ahead and revascularize. I think if you had tried to revascularize that graft to the RCA upfront, given the challenges with the engagement and the wiring and everything else, I think this guy may not have made it even to the end. So I think what you guys did was very reasonable. It's a good illustration of how the hemodynamics, how the approach with the surgeons on the table in a fresh case like this is something that's very important. I think you need the surgeons totally invested in the room with you to make these decisions. The other question here is, I think it was quite impressive to me, is that you guys started Cangalore on a guy post-CABG day one before taking him to the cath lab. I personally, am not sure how many of us in the room would have done that without shooting an angio first.
So I have maybe a controversial question. Based on the first set of hemodynamics that you showed in the cath lab with a normal cardiac output, high RA pressure, and not particularly high wedge or PA diastolic, and with the hypotension, I was actually wondering how many Impellas the patient needed and whether the left-sided Impella was absolutely necessary. Right. And I'd be interested in hearing the thoughts of the panel. Yeah. It seems like to me that the RP Impella was clearly the right answer, no question, but I was less confident that the Impella CP on the left side was beneficial. What do you think?
So I think at the point in the case when his blood pressure started dropping, I feel like it's almost a knee-jerk reaction to just grab something. And obviously at that point, the balloon pump wasn't offering enough support. So, but yeah, that's a point well taken.
Yeah, I think, as you say, it's a case of action-reaction. Sometimes you have to stop for a minute and go to the differential in your head and figure out what is the best step for that patient. And based on the clinical data that you have, I will agree with the fact that the patient probably needed more RV support than LV support. Now, as a patient also post-bypass, could be bleeding, could be having other things. So I think, as we talked yesterday, hypotension is not always have just one reason, and you have to stop and think, because you may just get worse outcomes by doing that.
Absolutely.
What do you think is the mechanism of the stenosis at the ostium of the graft? Do you think that was a stitch? It's probably too soon for fibrosis to actually happen.
Yeah, I mean, kind of running through the differential, usually vein graft early closure, you think about possible DIC, but that would usually affect all grafts. The location of the graft does lead you to think that there might have been some technical issue during the procedure, but nothing was listed during the OR report that would have suggested any issues, so I'm not really sure.
Yeah, I mean, the reason why I bring that up is that, if it is a stitch, I think you just have to tread lightly. I'd love to hear what Dr. Carr thinks about this. I, had a miserable case a few years ago where, fresh CABG has polymorphic VT taken back, and it's pretty clear that there is something wrong with the middle of a graft going to an obtuse marginal. As it turns out, that portion of the graft kept on leaking. They put a bunch of stitches in it. The stitch sort of pinched off the graft. I put up a stent. The graft ruptured. Then the cut ends of the graft retracted, and there was pretty much no way to salvage it. So we went right back to the OR, with a balloon up, going from the radial, guide balloon, plugging the hole until the graft could be replaced completely. Okay, thanks so much.